Hi, my name is Mackenzie Gakey, and I'm going to be critiquing the Gordon et al. Case. For context, Interleukin-6 is a cytokine that is produced in response to tissue damage and infections and starts with a cascade of events associated with inflammation. Much of the serious illness and death from Covid-19 is due to an excessive host inflammatory response, so limiting this response could be beneficial in reducing negative outcomes from Covid-19. Tocilizumab and sarilumab are monoclonal antibodies that inhibit IL-6 receptors and are used to treat inflammatory diseases. The study objective was to assess whether there is an association between the inhibition of Interleukin-6 using monoclonal antibodies such as tocilizumab and sarilumab and the amount of days respiratory or cardiovascular support was needed in severely ill patients infected by COVID-19. The study population consisted of critically ill patients who were 18 or older having COVID-19. They all were in the ICU and had to be enrolled in the study within 24 hours of starting either respiratory or cardiovascular organ support. These patients are classified as having serious disease that is still in the early stages where organ damage is likely to be reversible. 803 patients were randomly assigned to either tocilizumab, sarilumab, or no immune modulation. 792 patients completed the study. For the study design, REMAP-CAP was used, which is a randomized, embedded, multifactorial, adaptive platform trial for community-acquired pneumonia. REMAP-CAP is useful because it allows participants to receive multiple interventions which can be tested simultaneously. Proportions of patients assigned to each intervention were dependent on how many interventions were available. So, if a site did not have sarilumab, for instance, patients there were not assigned to that intervention. Exposure was measured as the drug a participant received, being either tocilizumab or sarilumab or no IL-6 receptor antagonist. The primary outcome was measured as the number of organ support-free days up to day 21. A day requiring organ support was recorded as a value of 0, and a day without requiring organ support was recorded as a value of 1. Additionally, all deaths within the hospital and within 21 days were assigned the worst outcome, which was -1. Among survivors, the values were added up, so a higher number represents faster recovery because it represents more days that respiratory or cardiovascular support was not needed. Statistical analysis was done using a Bayesian design which calculated median adjusted odds ratio with 95% credible intervals, mortality among groups, and posterior probabilities of superiority. Results were only disclosed if a predefined statistical criteria was met. Here, I'm going to cover my pertinent critiques of data collection. To begin, the primary outcome was the number of respiratory and cardiovascular organ support-free days as compared to the current standard of care. This is important because in a pandemic, the standard of care is changing as new research is collected. This means that the other treatments patients received changed as the study progressed. In this study, patients were randomized to a treatment domain as it became available. Tocilizumab became available in April, but sarilumab did not become available until June. So patients were not randomized to that treatment until 2 months after patients began receiving treatment for tocilizumab. This caused a drastic difference in sample size as 366 patients were assigned to the tocilizumab group and only 48 were assigned to receive sarilumab. However, all of the patients were still randomly assigned to a treatment group, so there was no bias in the assignment of patients to a study group. The main information was collected in a straightforward yes or no format, so there was likely no bias in information collection. Lastly, it is difficult to minimize confounding factors prior to data analysis, since each patient could potentially be receiving a different treatment outside of the treatment being studied. To control for confounding during data analysis, the model was adjusted for location, site, and country, age, sex, and time period to account for changes in clinical care and outcomes over time during the pandemic. This adequately adjusted for changes in treatment that some patients may have received, thus limiting the confounding that may have been present during data collection. The results of the study are listed here and show that patients receiving an IL-6 receptor inhibitor recovered quicker and had a lower in-hospital mortality. The interpretation is likely affected by bias relating to the different sample sizes. For instance, there were 9 serious adverse events reported in patients assigned to tocilizumab, but 0 in patients assigned to sarilumab. This makes sarilumab seem like a safer drug. However, 366 patients received tocilizumab, so the 9 adverse events that did occur were fairly rare. Only 48 patients were assigned to receive sarilumab, so the lack of adverse events could be because the sample size was too small. The discussion section did address limitations of the study, one of which being that the Bayesian design is unfamiliar to many clinicians, which makes the results difficult for many to correctly interpret. Additionally, the discussion section did reflect on other studies using IL-6 receptor antagonists on patients with COVID-19. Previous studies were conducted on patients who were less severely ill or who had been on a ventilator for longer than 24 hours. In these studies, no reduced mortality and little clinical benefit were found. Alternatively, in this study, patients were severely ill and had only been receiving respiratory or cardiovascular support within the last 24 hours. Therefore, it was concluded that the maximum clinical benefit from IL-6 receptor inhibition is likely seen in patients that are critically ill with COVID-19, but that are also treated early, while any developing organ dysfunction may still be reversible. Lastly, the results of this study can be generalized to the wider critically ill patient population with COVID-19, even though the standard of care may vary over time and by ICU. This concludes my presentation.